Okay, good morning to you all. Day before yesterday, we discussed about tympanic membrane perforated and mastoiditis. The mastoiditis was infected in the bone, and tympanic perforated was infected to the tympanic membrane. So that is also occur in the middle layer. And today we are going to discuss the otosclerosis. This also infected to the bone. Oh, sorry, this is the this inherited disease condition, progressive disease condition, occur in the middle and the inner layer. Okay, auto means you already know the otosclerosis. Okay, sclerosis means the bone. So what do you understand otosclerosis? Can you see from the slide the arrow, the black arrow here? Can you see? This is the this is the tympanic membrane. The tympanic membrane always collect the sound wave through the air canal and goes in through the eardrum, and these eardrum are protected by the three bone that is called ossicles, and this is Milius, incus, and step. So mainly, what is happened? It's in fact it's autoimmune disease, like in hereditary disease, progressive into the bone. So can you see from the slide here how it's growth, just like a cauliflower? This is the ASIC, the otosclerosis, how the bone are forming. The osteoclast, instead of forming the osteoclast, it is degenerative, okay? And we'll see the next slide. What today's the outline is given here. Related anatomy and related anatomy part we will discuss related to the osteosclerosis, then the pathogenesis, then clinical features, diagnosis, treatment, and complications. These all are going to discuss now. And the first of all, we'll discuss related anatomy. Okay. In the related anatomy, before discussing these otic capsules, otic livrin, and periotic livrin. So the next slide, from the slide, can you see how the osteosclerotic bone is forming in the front of ear? Can you see the pictures? Yes? Yes or no?
Yes, ma'am.
Yes.
No,
See,
ma'am.
this is the osteosclerosis. You can see very clearly in the pictures and where it's affected in the which bone. This is the, what is this bone? Step. Okay, the Milius and incus is here connected with this step. It's already the growth. Abnormal bone growth is happen inside the middle ear. This is the otosclerotic bone front of the ear, and these all are the structure of the ear. Okay, so we will discuss one by one. The previous slide, otic capsule. Otic capsules, otic livrin, and periotic livrin, these are forming inside the ear. Okay, this is the organ. What do we understand otic capsules? Otic capsules are the embryonic cartilage capsule that surround the inner ear of the inner ear. And what are the mechanism of the otic capsules are developed into the bony tissue. So the normal development of bony tissue are called osteoclasts. Okay? So it's normally supposed to form inside in our ear, but in this condition it's abnormal growth of bone are forming inside the eardrum or maybe in the inner ear. Because of that, the persons are complain of conductive hearing loss, progressive conducting hearing loss. And the second is otic livrin. When we say about the livrin, are included articles, utricles, sacule, cochlea, semicircular canal, endolymphatic duct, and the sac are included into the otic livrin. Okay, then the periotic livrin, the perilymphatic liver. Huh? You have seen from the pictures there is we have the lymphatic. One is the perilymph and one is the endolymph. Endolymph is inside, surrounded by the perilymph. And the endolymph and the perilymph are carrying fluid and continuing to the cerebrospinal fluid. These are the structure I will show in the pictures in the later slide. Just try to understand the anatomy part so that we will understand more when we discuss about the disease condition. Okay, these are the three. What all are included under these subtopics. Are you getting me? Go to the next slide. Already I have shown. Okay, see, when we talk about the otic capsule is the bony liverin. Okay, this bony liverin also is called this one. Bony liverin, sorry. Then this is the membranous liverin. This is the bone part, okay? That's why it's called bony liverin. Okay? This is membranous liverin. Understood? These two pictures? Yes or no? Yes. The bony liverin and the membranous liverin with the nerve, and this also included in our inner ear. And the second slide, see, you will understand more now. When we talk about the bony liverin is also called endolymph, and membranous liverin are the perilymph, and these are this endolymph is inside, and the perilymph are surrounded to the endolymph. Okay, so all cochlear duct, round window, oval window, ampulla, posterior semilunar duct, these all are the anatomy structure of the inner ear. Okay, and the earlier slide, in the earlier slide, see, when we talk about the otic liverin, okay, otic liverin, what all part are consist? Ventricle, sacula, cochlear, semicircular canal, endolymphatic duct, and the cell. These are the otic liverin. Okay, and this is parietic liverin are tympanic and perilymphatic space around the semicircular canal. Okay, consists of scala vestibuli. See this structure I will show you. Sorry, the previous slide. See the parietic endolymph. Okay, scala stibuli, cochlear duct, and scala tympani. Okay, these are the parietic endolymph. Then when we discuss about other, okay, this is the step. Many pictures are there because this is lots of confusion. That's why I'm trying to show from the pictures so that you will understand more. But don't get confused. If you confused, please tell me. Okay. Now you understand up to here? Yes? Endolymph, perilymph.
Yes.
And this is the cochlea, and this is cochlear duct. Okay? Superior and posterior semicircular duct will be there. Then this is the vestibule. This is the ampulla. Okay? This superior semicircular canal. Then vestibule, ampulla. Again, it's called what? Otic liverin. Okay? Are you understand? Yes? Please give answer. And this is the membranous liverin. Again, more clear here. When we discuss about otosclerosis, it's mainly affected to the bone. I already mentioned in the earlier. And the complication, it will come. You try to see the dura mater. Okay? And then scala vestibuli, cochlear ducts, scala tympani. Okay, the round window, step in oval window, articles. Okay, this ampulla, lateral semicircular canal. Because why we are showing here, whatever we have shown here in the inner ear part, the bony liverin are mainly affected. That's why we are trying to correlate with the structure and what we explain. Okay. Second slide, see. This is, see. In our inner ear, the endolymph also carry the fluid. Okay? What are the fluid? What are the electrolytes? Sodium, potassium, and chloride are carry in the endolymphatic sac. Then cochlea also carries sodium, potassium, and chloride. And the vestibule also carry the electrolyte, but chlorine is absent. Okay, that's why you heard about the tinnitus and all. So here the lymphatic and lymphatic perilymph and the endolymph, both these organs are carry fluid and continue to the cerebrospinal fluid. And how it's important, since it carries all the electrolyte. It's very important. Okay. And next, let's see, when we talk about the otosclerosis, osteo and auto, I'm always confused. Otosclerosis. Otosclerosis is the hereditary disease, progressive deafness due to overgrowth of bone in the inner ear. This is the simple definition. The primary disease of the bony otic capsules. What we discuss are the otic capsule, are the bony librine. Okay? Characterized by the abnormal removal of mature bone by osteoclast. Osteoclast is the multinucleated cells contains microsome and ribosome, and that's two ribosome and this one are responsible for the reabsorption. And in our bone, in the ear or the others area, the bony part are uh, processing in this process, resorption of the bone with these two. This is the normal function and the normal process. But in the otosclerosis condition, there is an abnormal replacement. What all are replaced? Even bone of the greater thickness, cellularity and the vascularity. Is the totally growth, abnormal growth are replacing. That means this is the hereditary inherent disease, okay, and the progressive of abnormal growth tissue are replacing instead of the osteoclast process. Okay? Understood? Yes or no?
Yes, ma'am.
Okay, next slide. The clinical features autosomal dominant hereditary disease. It's considered as a autosomal dominant hereditary disease and lead to the progressive conductive hearing loss. This is progressive. Okay, when the persons come to the clinic, mainly this sign symptom will be present. Most common cause of conductive hearing loss in adult, the bilateral hearing loss also can be occur in the 70% of case. And the male and the female ratio is 1:2. The most commonly affected age group is 15 to 45 years old with the hearing loss manifesting typically in the third decade. Cochlear otosclerosis manifests with sensory neural hearing loss. That means it's affected in the inner ear. It will consider as a sensory neural hearing loss. This is the permanent loss. Okay, the next slide. What are the etiology? The exact cause is unknown, but many factors have been responsible, such as hereditary, the endocrine problem, then trauma, infectious like example measles and vascular disease or the autoimmune disease can be occur. Are the etiology. Pathogenesis. What is the pathogenesis? Okay, the pathogenesis is the manner of development of the disease condition. In this progressive and development of disease condition has two phases, early phase and late phase. Okay, In the early spongenic phase, the osteocyte and histiocyte and osteoclast are normally just mild and moderately deteriorated. It's present in the active resorptions of the bone. This is hyperemia, just like the actively. That means started deteriorating, not a normal process. If start active, then stent blue mantled on using HE stent. You will understand what is this HE stent in the next slide. Dilated vessels, swan sign. Swan signs is also the one diagnostic procedure. Diagnostic procedure. It's also called flamingo's pink sign. This is a diagnostic indicator for the otosclerosis. Okay, this disease of the bone of the middle or the inner ear. In clinical examination of the eardrum, increase the vascularity of the inner and middle ear. This is like the diagnostic procedure. Okay, when we examine, then it will seem that this is the abnormal growth and increase in the vascularity. Okay, the later or the sclerotic phase. Okay, the early phase it's called otospongiosis, and the later or the sclerotic phase, that is the second phase. Okay, formation of new bone in resorption area. Okay, new bone is dense and sclerotic. It's become more thickened. Stains red on using HE stain. Before was blue and now it's coming to red. Start in endochondral bone, then involves the endosteal and the periosteal layers and the membranous ligament as the disease progresses. You can see from the next slide. See, histopathology. What is histopathology? Anyone? Histology, osteosclerosis with a small focus in the anterior oval window. You can see the arrow, how it's formed. Okay? Histopathology means what is that?
Yes, ma'am.
Diagnosis and study disease of the cell and the tissue. Okay? How they diagnose? What I have told you in the early slide. Okay? See, pathogenesis. This is the progressive one. Phase 1 and phase 2. And now comes the histopathology. In the clinically, they are examined under the microscope, taken the patient's tissue. Okay? And this is the histopathology. Can you see these two? Yes, small focus in the anterior oval window. There is histology, osteosclerosis with a small focus, this one, this area. But the clinical otosclerosis, the lesion has spread across the annular ligament and fixed the stem. Yes? You see the difference? This is already fixed one. Please,
Yes, ma'am.
confused or not?
Yes, ma'am.
Confused?
Confused.
Confused?
Yes.
Confused?
Yes, ma'am. Confused. Yes. Yes, ma'am.
Confused. Okay, see, this is the histologic otosclerosis with a small focus in the anterior oval window. How is the growth? Can you see the growth? Yes? And then here it's already, it has to be connected, no? Yes. Yes or no? But the clinical,
Yes, ma'am.
Clinical otosclerosis, the lesion has spread across the annular ligament. Already spread, but already this here the empty, here no empty, but already fixation done. Understood? This is the disease progress and how the otosclerosis forming here, and the plate is already broken, but here already spreading, but already the steps already fixed. Understood? Yes? Yes or no?
Yes, ma'am.
The types of step
Yes,
gel
ma'am.
fixation. How do we fix? Anteriorly can be fixed, posterior or circumferential, biscuit type and obliterative. These are the types of step gel fixation. So you have already seen in the earlier slide how it's fixed. Sorry. Okay? This is the types of step gel fixation. And the other area also can be, you know, included, means affected. Round window, the effects of the cochlear aqueduct, the semicircular canal, and the staph footplate itself also can be involved. The hearing loss, the mainly conductive or sensory neural or the mix. Since we already mentioned that there is a progressive hearing loss because of the abnormal growth of bone are replaced in the either inner ear or in the middle ear. The diagnosis, differential diagnosis. First of all, we are taking history from the patient. When we take the history, the gradual onset of hearing loss progressing slowly. Then 70% of cases hearing loss is bilateral. Usually becomes apparent around the age of 30. Loss of noticeable when it's reached 25 to 30 decibel. Means in the odometric trace. You can see from the later slide. Then unilateral loss of notice, even later problem with the localization of sound, tinnitus and positive family history you can find. The physical examination, in the physical examination, otoscopy going to be performed, the Schwartz sign, already I mentioned earlier, the red bloods occasionally seen over the promontory or the anterior to oval window. Pneumo-otoscopy used to rule out other cause of conductive hearing loss such as middle ear, surround fluid or small perforations. And the tuning fork test also has to be performed, that is Weaver test and the Rennie test. Okay? These are the examination, otoscopy and pneumo-otoscopy and tuning fork. These three are the examination. Examination can be performed to the patients. Weber test you already understood. Okay? Lateralize and with the 5 decibel of conductive hearing loss. And then Rennie test. Then odometry. You all understood what is odometry, how we are examining the patients and uh, how we perform the odometry test to the patients and the speech odometry. Okay? And the independence odometry, how the curve is shown here. Then acoustic reflex, what all are the reflex? A is the normal compliances, B is the phasic, okay, and C is the fixed compliances. And radiological investigation is high resolution of CT scan or the MRI. If the CT scans are not clear and we cannot observe, then we can go for MRI for better understanding and better knowledge for the treating the patients. Now comes to the treatment. Treatment modality is the first option is hearing aid, surgical management, observation or the medical management. Based on the patient's condition, we have to decide. Medical management, what do we, what is our uh, what is our aim? Aim is to stabilize the disease by reduction of the osteoclastic bone resorptions, increase osteoblastic bone formations. So we want to minimize the abnormal growth of the bone and inhibit proteolytic enzymes that are cytotoxic to the cochlea. We want to minimize the infected or you know we want to develop in the proper manner. Then slows the progressions of sensory neural hearing loss. It's not commonly used. Then the sodium fluoride therapy. Sodium fluoride therapy can be administered but contraindicated in patients with a chronic nephritis and a chronic rheumatoid arthritis, pregnant and lactating women and children. But bisphosphonates, these are the binding site on the bony surface, especially surface undergoing the active reabsorption. And this is going to help for reabsorption of the bone. It's helping in osteoclast. Okay. Hearing aids very effective in early stage of disease but can be used in advanced stage if surgery is contraindicated. If the surgery is contraindicated, then we can use hearing aids effectively. Patients refuse the surgery if by chance, if they refuse. In far advanced cases, it is required even after staptotomy. Surgical management, bora air always chosen for surgery. Don't preferably under the local anesthesia so patients can notify by surgeon if vertigo occurs during procedures. Options are staptotomy and stapdectomy. One is opening or one is removal. Lesser complication due to use of laser now. And the selections criteria for what we spoken earlier, hearing threshold is 30 decibel or worse. Surgical management. Okay, the next is selection criteria. If the patient's hearing threshold is 30 decibel or worse, then only the candidate for surgery, for the hearing, or maybe the surgery selection criteria. Since we discussed about the surgical management, AB gap at least 15 decibel, then Rini negative for 256 Hz or the 512 Hz. What we use in the word the tuning fork, there is last time also I mentioned about started from the 256 to 512, but normally in the word we are using up to 400 Hz. Okay. The split discrimination score is 60% or more. Split discrimination means when we ask or when we discuss, maybe the patients are not fully understand, no? Then prosthesis. What is that? This is the grafting. Grafting of artificials are putting inside the ear. Prosthesis. You understood, no? Using the material of Teflon piston or stainless steel piston and platinum Teflon piston or titanium Teflon piston. Those are the material using for the grafting. And summary of small fenestra staptotomy. These are the procedure and they are summarizing here. Manasseh, can you read?
Yes, ma'am.
Yes, read. Small procedure.
Summary of small fenestra
Mm.
stepidotomy.
Mm.
Anesthesia injected. Incisions at lateral process of malleus and inferiorly. Tympanometal flap elevated. Adequate exposure. Facial nerve superiorly. Pyramidal process inferiorly. Distance from incus to foot plate measured usually 4.5 mm. Microdrill used to create fenestra. Prosthesis placed on incus and firmly in place. Incudostapedial joint separated and stapedial tendon sectioned. Stapes superstructured, fractured and removed. Prosthesis checked. Tympanometal flap returned to normal position.
Actually, it is, you have seen from the pictures also, it's already broken up, no? Because the normal process of reabsorption of the bone and that process is totally degenerated. That's why the bone absorption, if the normal process bone absorption, that means in either in the inner or the middle ear, it will not be break up, and there is no accumulation of and we will not see any increase of vascularity. And this is because of the abnormal formations, it's already break up and or it's in the complicated form. So we are taking out that abnormality and replace the prosthesis, which one it's selected by the surgeon, and we replace it. And but if it's affected on the ossicles, then do you think that we will able to hear? Tympanic membranes are collecting sound, okay, and support with that ossicle. But this affected in that bone, and it's the abnormal growth. And how that the wave will go through that all this process, it will be affected, no? Understood? And you have seen in the early slide that how it's replaced and the structure. Yes? See, the prosthesis placed on incus and cramp firmly in place. Incudostepdial joint separated and the stepdial tendon section. So partly they are uh, distinguished, and which part is affected take out and putting the this one the material. Okay? Yes or no? Understood?
Yes, ma'am.
Yes, madam.
These are the very complicated one, but we are not the surgeon, and just we are taking up and trying to take the concept from the book only. No? There is real situation we have not seen. But we have learned from the anatomy part what are the normal structure of the inner and the middle ear, in the how the bone are affected because of the normal growth, because of the this due to the inherent disease condition. This is like autoimmune, no, and the cause is unknown. Maybe it's affected from the child 15 to 30, means up to the adult. Okay, due to the this and that, nothing. This is the causes is unknown, no. Understood? These are
Yes, ma'am.
steptotomy, Sheffer. This is the Sheffer method, but lower rate of high frequency sensory neural hearing loss post-op. This is the lower rate, but steptotomy, the less chance of recurrence. So, what will be the decision for the patients? Based on the patient's condition, and the surgeon will decide. Post-operative care, patients had elevated 30° to reduce the peri-lymph pressure in vestibule. And the bed rest for at least 1 hour. If no vertigo on getting up, then the patient can go home. Patients can resume air travel after 5 days. Follow up with audiogram in 3 weeks. The ENT, since we learn from the different unit, ENT again are very different. Okay, the criteria of selecting the patients and taking care of the patients pre and the post. Okay, the post-operative care also very important, and discuss the different part. Okay, and this, do you think that ENT is totally different, no, from the others, neuro and ENT? Yes or no? Yes?
Yes, ma'am.
Okay, that's why if you are posted in the ENT area, then after this all the procedure and how you are going to receive the patients and how you are going to follow the surgeon instruction, that we also the healthcare persons and we need to take responsibility after the post surgery and totally hand it over to us, and we are the one only for front line and going to taking the responsibility for the patients, the shift duty. Okay, the post-operative care are very important. Again, we have to follow that, and you should able to give the handing over to the next staff that these patients are operation done, and these are the instructions we are following. The remaining you have to continue. Yes or no? Okay. We have to
Yes.
make the 30-degree. Then at
Yes,
least we
ma'am.
will 30-degree. At least we will allow the person to bed rest for the 1 hour, and we will examine the patient that after the 1 hour whether can get up or not. When we get up from the bed, any signs, any symptoms are present to the patient, accordingly we will treat. Then if nothing is happened, then patient can go home, and then we have to instruct the patients after 5 days or the 1 week you can travel. Okay, the follow up with the audiogram after the 3 weeks or maybe after the 1 month will be allowed. Then contraindication. What contraindications? Since we discussed, yes, Chenogi. Since we discussed what is the contraindications, what do you understand now? Yes, contraindication for the surgery or contraindication for the medication?
Ma'am,
Yes.
I'm only hearing ear.
No, what do you understand from this
Occupation.
contraindication? These all post-op surgery are contraindicated if the patients are here only hearing. If the persons can hear, then we will not do surgery. Yes, Chinogi? Contraindication means if the patients
Yes,
can
ma'am.
hear, then we will not perform surgery. Then if the persons have the Meniere disease, this in the next class you will understand what is the Meniere disease. Infected to the this one. Meniere disease is in the it's the fluid, regarding the fluid. Okay. Then the occupations, those who are working, they experience frequent change in pressure, work in noisy surroundings, otitis externa, perforated tympanic membrane, young children, poor state of health. Those patients are contraindicated for surgery. Complications, post-operative complication, exposed over hanging facial nerve, maybe 9% can arise complication, chordae tympani nerve damage, 30%, solid or obliterated foot plate, then floating foot plate. Okay, after putting, maybe it's coming out already and float on the inside the ear. Okay, the solid or obliterated foot plate, these two. Then the persistent stapedial artery, then perilymph gusser, managed by placing tissue graft over oval window, tympanic membrane perforations or intraoperative vertigo due to the long prosthesis and the fixed milius. Those are the complications, and we have to be very careful. And this is just percentage, but if we all are thinking about the complication and no one is going to perform for surgery, right? Yes or no? But still we have to
Yes, ma'am.
still we have to know that what all are the complications so that we can take more precaution before and after hand. Okay, post-operative complication and vertigo, facial paralysis, tinnitus, this also the same thing. Hmm? This is the intraoperative complication and post-operative complication. This slide are a bit complicated, but I don't know how far you understand or very confused. I don't know. Very confused or understood? This is the last slide. Don't worry. Hmm? Intraoperative complication and post-operative complications. These are the post-operative complications. Iba, can you read? Vertigo?
Yes.
Yes, can you read?
Uh, yes, ma'am. Operative complication. SNHL, vertigo paralysis, disturb perineum fistula that ear 1% intro, uh,
Introgenic tympanic
aerodynamic
membrane Iatrogenic tympanic membrane perforation. These are the most complicated. And this otosclerosis are very complicated. And please remember that this is the hereditary disease and inherited. It's so far the book has shown. And the cause is totally unknown. Okay? And this is not the infective process. Yes or no? Okay, any doubt? We'll finish here. Okay, then thank you.